Welcome back. I hope you managed to get some time for networking and refreshed. We've got two sessions this afternoon. The first one is the surgical session, and I'd like to welcome again our co-chairs, Ben Stanger and Nilo Azad. Thank you.
Thank you, Juan. So on behalf of myself and Nilo, happy to introduce this next session. We have two leaders of this working group sitting up here with me. There's Bas-Groet Korkamp, who is a surgeon epidemiologist at Erasmus, specializing in hepatobiliary and pancreatic surgery, and Shishir Mittal, who's a professor of surgery and chief of the Division of Surgical Oncology at Northwestern University. So please take it away.
Awesome. Thank you all, and hope you enjoyed lunch. We're excited to present this. If we could have next slide. I just wanted to introduce this, our working group. We had multiple meetings throughout the last few months organizing our thoughts to come up with some good ideas and for RFPs that could really drive the field forward. I do want to acknowledge the group there and also really call out Mary Ott. She was unfortunately got sick and couldn't attend the conference today, but very much appreciated all the input from a patient perspective into all of our discussions. Our group basically divided our task into three subgroups. One focusing on the classification of disease, resectable, borderline resectable, locally advanced, really kind of aiming towards standardization of terminology. Next group focused on perioperative therapy for early stage resectable disease or borderline resectable disease. And our final group focused on transplant. So our presentations will be done by our co-chairs of each of our groups. So for the first one, I'd like to bring up Gonzalo Sapasoshin, who will be talking about the classification.
Good afternoon, everyone. Really an honor to be here with all of you. So as Shishir mentioned, I'm going to be talking mainly about the classification, and I'm talking obviously on the behalf of four of other colleagues that helped develop this. So just briefly, as many of you know, resectability for cholangiocarcinoma is really not well defined, and it's, there's a couple of reasons. One is because the anatomy is very heterogeneous, and then, surgeons have different, they're confident doing different things, so it's very subjective to assess what's resectable or not. The problem we find is that even resection being the best treatment, even after resection, the outcomes are not great, even in our zero resections. And, we do know that as the field is moving forward, like with other hepatobiliary malignancies such as hepatocellular carcinoma, pancreas cancer, it is going to be very important, especially if we start thinking about, trials in the neoadjuvant setting to really define what is resectable. And this definition, as I said, should really define or help us, design those trials. So when we think about resectability of patients with cholangiocarcinoma, this is what we think are the main factors we take into account. It's anatomical and technical. Then there's, patient factors, including, liver function, the remnant of liver we're leaving behind. And then obviously there's some oncological and biological factors that are very important, some of which are really, not well defined and will also define, help us design future strategies. So what we did, and we did this within our group, but also with the help of my research lab and many of our fellows, we did a big systematic review to try and identify, known risk factors to then be able to define what patients should be upfront resectable, some patients that would be borderline, and some patients that are clearly unresectable. And we reviewed a lot of papers, and I'm not going to go through all of this, but as you can see, this Prisma chart shows that we've reviewed a lot of papers, and with all of these, we're going to try and describe a little bit what the proposed definitions for resectability in cholangiocarcinoma are, and we're going to talk obviously about the different cholangiocarcinomas, including intrahepatic, hilar, gallbladder, and distal. And I would also like to mention that there's been also an initiative with the cost action on the ENDS cholangiocarcinoma, so this was very timely that we were doing this among both groups. So this is the first kind of assessment we did on literature, and this is just all the published adjuvant trials that have been up to date, and just not to go into detail, but on the right of your screen, you can see the risk factors that came out on adjuvant trials. And these are some factors that then we're going to use to design what are patients at high risk of recurrence after surgery. As I mentioned too, and I'm not going to go through all of this, but this is data from meta-analysis that describe different risk factors depending on different characteristics for resection of specifically intrahepatic cholangiocarcinoma, which is the first topic we're going to describe and assess what is borderline or what is unresectable. So our group came, and I guess the slide just moved, but this is supposed to say intrahepatic cholangiocarcinoma. So our group came with these definitions with what we consider resectable intrahepatic cholangiocarcinoma, and these are single tumors, small tumors that don't have positive nodes, that don't have vascular invasion, that don't need vascular reconstructions, and then obviously that they can be resected safely because the liver is good enough and we can leave enough future liver remnant. I'm actually going to move to the other spectrum completely, which is the unresectable disease. And we define unresectable patients that have N1 disease, that have nodes that are beyond the porta, or that have multilobal bilobar disease. But what is more tricky, and this is where this definition is important, especially if we're thinking about neoadjuvant trials, is that concept of borderline resectable. And the way we define this was patients with multifocal unilobar, single tumors more than 5, tumors that have satellites, patients that have periportal nodes, if they need a vascular reconstruction, or if surgeons and radiologists on their assessment think that you're going to end up with an R1 margin. And obviously, if you have one of the factors, then you're already set in one of the columns. You just need one of them. So these would be the definitions for intrahepatic cholangiocarcinoma. So for HILAR, there has been previous studies, and BAS participated in this study that already did some national consensus, and this was in the Netherlands, on definitions of what's clearly resectable, what's borderline resectable, and what's clearly unresectable. And I think with this study there was a little bit of definition. I think what we've tried to do is to take it to the next level. So again, as I mentioned, and I'm not going to go through this slide, but this is just to show you that we did a full systematic review, and this is data from meta-analysis that identify risk factors for worse outcome or risk factors for recurrence in patients that had surgery for hilar cholangiocarcinoma. So going to a similar description of what I described for intrahepatic cholangiocarcinoma, we defined resectable disease, tumors that are confined to the first order of the bile ducts. They don't have nodes that are pathologic or seem pathologic on radiology, they don't need vascular resection, and they don't have vascular invasion. And again, from a liver perspective, patients that you're going to be able to leave at least 30% of the liver. Again, I'm going to move to the other kind of spectrum, which is clearly unresectable. And as you can see, obviously, patients that have extrahepatic disease, metastatic disease, or have tumors beyond the second order bile duct. And we define borderline and a potential for neoadjuvant trials, tumors that are beyond the first order, invading the second order, patients that have positive portal nodes but not beyond the portal nodes, patients that have vascular invasion that need reconstruction, or if you think you're going to end up with an R1 margin. And this would be our definition of borderline resectable hilar cholangiocarcinoma. Moving to gallbladder cancer, obviously the data is a little bit more scarce, so we didn't have so many risk factors, but many of them, again, came in these different meta-analyses, and we, again, defined or created these definitions of what we consider resectable, unresectable, or borderline resectable. Resectable patients were, similar to the other cholangiocarcinomas, single tumors that don't invade other structures. As you know, gallbladder cancer tends to invade locally, so don't invade any structures. You don't need to do vascular reconstruction, and there's no nodes. If they have extrahepatic disease, metastatic disease, then including intrahepatic metastasis, then they're clearly unresectable. And patients that are borderline would be those that have local invasion, like the colon or the duodenum. They have portal lymph nodes, or you need to do a vascular resection, or you're at risk of developing an R1 an R1 margin. So finally, we did a little bit similar with the distal cholangiocarcinoma, and I think one of the things that we discussed a lot within our group, and there's going to be some important information about this, is that it's also very difficult to distinguish what's distal cholangiocarcinoma to what is pancreas cancer, and if we should be using the resectability criteria for pancreas cancer or for distal cholangiocarcinoma, that we probably shouldn't, and there should be a clear distinction. But what we came is that resectable tumors that have, or distal cholangiocarcinoma that are clearly resectable, are those confined below the cystic duct. They don't have nodes, or they don't need vascular resection. Again, if they have liver metastases, if they've developed disease even outside of the liver, or pathological nodes beyond the porta, then they're clearly unresectable. And the definition of borderline resectable tumors would be those that extend above the cystic duct, in which case, you may be at risk that you need to do both a hepatectomy and a Whipple. Again, if you are at risk of developing an R1 resection, if you have portal nodes that seem positive or confirmed to be positive, or you need to do a vascular resection. So this was kind of the description, and then I guess we'll go to the voting. Shishir, you want me to go to the questions, to the recommendations? Okay. So these would be the recommendations we think we should put forward. So one would be, and I guess we'll afterwards vote, but one would be that defining the ideal optimal imaging characteristics, modality, and serological factors, like tumor markers, ctDNA, et cetera, for accurate staging, and using a defined common language terminology should be or is a research priority. And secondly, that defining the criteria for preoperatively distinguishing distal cholangiocarcinoma from pancreas cancer is also a research priority. So I guess with this, we can go to the voting.
So I'm just going to ask that, unlike the last session, we hold any discussion or question until after the initial vote, unless there's a really burning point of clarification. Did you have something you wanted to?
No, I just wanted, in terms of what we just read, it's just define the ideal, define the ideal optimal imaging characteristics and serologic factors for accurate staging and defining resectability using standard common language terminology.
Yep.
Can you reset the clock? Thanks. You have to vote, Shisha. We have a chance of music. Disagree, okay?
It must have been cold there in my shadow to never have sunlight on your face.
So I will admit to being the person that asked for the more fun music for the music.
Thank you. That's good.
We'll see what happens.
So
We'll move on to the next recommendation, because I think this the first one was clearly accepted. Recommendation number 2, defining the criteria for preoperatively distinguishing distal cholangiocarcinoma from pancreas cancer is a research priority.
I hope you never lose your sense of wonder. You get your fill to eat, but always keep that hunger. May you never take one single.
So there is no definitive agreement here, for which the cutoff is 80%. I'm just looking at Juan now. I think we're going to discuss this right now. Maybe one reason might be that, just for the sake of time, this has not been really the focus of your presentation, right? So
Yep.
maybe there is room for discussion.
Can we have the lights up a little bit?
Maybe I can just clarify about this recommendation, since we didn't discuss this in detail. So pancreatic cancer is much more common than distal cholangiocarcinoma. And for pancreatic cancer, increasingly patients are treated with neoadjuvant treatment. And sometimes on preoperative imaging, even with EUS, it can be difficult to definitively tell whether a lesion is pancreatic cancer or distal cholangiocarcinoma. You can see that, for example, that in all neoadjuvant trials for pancreatic cancer, there's always about 5% of patients who after surgery turn out to have pancreatic cancer. Distal cholangiocarcinoma rather than pancreatic cancer. So for future research, it would really be helpful to be able to determine this preoperatively. Because if you want to do, for example, study a neoadjuvant treatment for distal cholangiocarcinoma, you need to be as certain as possible that the imaging you're looking at is distal cholangiocarcinoma rather than pancreatic cancer. Maybe Gonzalo, do you have anything to add to that?
No, I mean, I think that's the key point that I wanted to make. I think it's important. I think there's a couple of questions.
Microphone 2.
Rando?
Thanks. So this is Vikram Deshpande from Bethesda Deaconess Medical Center. I'm a pathologist, so I think one of the issues we have is, what's your gold standard? If you consider pathology as the gold standard, I can tell you that I and my neighbor don't agree with one another. And there's some publications on that as well. So we have trouble with the gold standard, which is why I have trouble with that question as well.
Yeah, I get what to compare it to. I guess that's the point. Yeah, yeah.
That is a difficulty, I agree, but I think that only reinforces the research priority. If you don't even have a gold standard, I would say that's an additional reason to investigate this distinguishment, because otherwise we can't do prospective trials. Alejandro?
I don't have any concerns with the statement. Probably my main concern is the priority of this question. I think this is not a priority question in surgery. This is my only concern. I think there are a lot of much more important problems with the surgical resection of cholangiocarcinoma rather than to distinguish distal cholangiocarcinoma versus pancreatic cancer.
Yeah, I mean,
this is my opinion as a clinician.
Yeah, I mean, I don't think it's a bad point. I mean, I don't think it's a correct point. I think that the point is what Bas was trying to describe, that if the whole point of this surgical, and we're going to talk about neoadjuvant afterwards, but is the neoadjuvant setting, and then you need to distinguish because the therapies are so different. But I guess
one more comment from Dr. Gores.
Yes, so I agree with the first two questioners. One is this a priority? Two, what is your gold standard? And then what's the need to know? And the need to know is only if you have a neoadjuvant therapy that's going to be effective and markedly different between the two.
Yeah.
That's a good additional point, but of course, if we can't, we have treatments for cholangiocarcinoma, and they're to a large extent different from those for pancreatic cancer. And if and there's reason to believe, to hypothesize at least, that a neoadjuvant approach might also benefit patients with distal cholangiocarcinoma. The only way to investigate it is to do a clinical trial. And the only way to do a clinical trial is to select patients up front at baseline. Mm-hmm.
So I'm not hearing any changes in the text.
I just want to make one other comment in terms of really emphasizing the need for the field to understand this in order to move forward with neoadjuvant or perioperative therapy trials for distal cholangio. This is already a research priority for intrahepatic cholangio, where many patients are getting therapy prior to resection, whether it's resectable or borderline resectable as we defined it. For hilar cholangio, we're moving towards that. A lot of places are now, as they are re-looking at their transplant protocols, people are redefining their pre-transplant therapies. What's the role of immunotherapy? What's the role of chemotherapy? What's the role of radiation prior to transplant for hilar, since you're taking out the whole thing? So if we're doing that for intrahepatic and we're doing that for hilar, I do feel that for distal, it's kind of being left off as an orphan because we can't tell the difference. Mm-hmm. And as you know, radiographically, it's very hard, but that's why we have genetics as our NGS gets better, our pathologic analysis, we take it to the next level as opposed to H&E, using serologic things. In order for the distal cholangio patients to be enlisted in these types of trials, like our hilar patients and like our intrahepatic, this is an absolute must. That's my opinion.
All right, let's move forward with seeing if the conversation has convinced any of our disagreeers. We'll vote again.
While we're voting, I would like to ask Juan, when we're voting here, should we take into consideration the importance of this statement compared to the other 55 statements today?
Yes, it's a good question. What we're not going to do as a part of this conference is to prioritize then this particular surgical question over another question, maybe in pathology or radiation. I think what we want to know is that each of the questions stand in their own right as a priority. How the research is funded for each of those will probably come from different streams. So there may be a call, for example, for development of new biomarkers, and then the research priorities that align with that call would then be something that can be put forward for an application, and we'd be kind of ready to put something in for that. Something that focuses a bit more, let's say, on palliative care, for example, would then be that any questions that are addressing palliative care would then be ideal for that specific grant call. So it's not that we're prioritizing for a single winner, as it were, but we do want to know within each category what are the key questions that we need to be considering as a community.
Can we vote now? Can you please set the timer again? Thank you.
Like a small boat.
So for the professionals, there's no consensus. For the patient caregivers is, but so I think we'll move on. So we'll move on. Thank you, Gonzalo. We'll move on to the next presentation. So the second topic of our working group is a perioperative therapy, focusing on a neoadjuvant treatment. And the speaker on behalf of the team is Hop Tran Kao. Thank you.
Good afternoon, everybody. So I want to preface this presentation by telling you that when we discuss this, we really focus on intrahepatic cholangiocarcinoma for some of the reasons that have already been mentioned, which is the challenges in establishing diagnosis with distal cholangio, and likewise for tissue diagnosis, as well as problems with biliary obstruction and cholangitis with hyalocholangio. So we really kind of focus on intrahepatic cholangiocarcinoma. We know that despite our best efforts, surgery alone or even surgery with adjuvant therapy hasn't yielded durable, long-term successful outcomes. And especially in the presence of certain risk factors that Gonzalo has already outlined that make the disease what we call borderline resectable or high-risk resectable, the recurrence is really, really high. And so adoption of a different approach where we use chemotherapy or systemic therapy ahead of surgery is enticing and kind of, in a sense, imitates what we do with a lot of other aggressive cancers like pancreas cancer, with some potential benefits, such as tumor downsizing to achieve greater rates of R0 resection, early systemic therapy for micrometastatic or occult disease that's spread already, improved patient selection for surgery to make sure that those patients will benefit from the operation that can be pretty morbid or aggressive, and ultimately allow us to tell whether the disease biology will respond to systemic therapy. When you look at the neoadjuvant therapy for intrahepatic cholangiocarcinoma, whether it be national data or single institution like MD Anderson, we know that if you're able to get through systemic therapy and get the surgery, the outcomes tend to be better than if you just did surgery up front. However, there's a lot of questions still to be defined, which is certainly on the patient side, there's still a lot of anxiety, right? We know, and I appreciate Mary for her contributions in giving us these thoughts here, that patients, of course, are in a hurry and want to have their tumors removed. But ultimately, what matters more, than speed is success, right? You want to make sure that you're going to have the best chance for a long-term outcome that is good and that favors long survival. And so because of this, I think patients are definitely interested in supporting a neoadjuvant approach or a new thought process, but they want to be involved. And I think this is really key and something for us to all keep in mind as we think about clinical trial concepts. At the same time, there's a lot of questions as to what we should be using. John has told us that in the adjuvant setting, capecitabine is the standard of care. Now, at the same time, in the systemic disease standpoint, we know that Gemcis with immunotherapy is the standard of care. At the same time, paclitaxel hasn't quite, fallen completely out of favor because it does seem to potentially have an effect in the localized setting. We also know that there's a plethora of targeted therapies available for intrahepatic cholangiocarcinoma, depending on the mutation of the disease. So which of these agents should we be using? In what context? These remain unanswered questions. Now, we do have one trial that has completed accrual, a completed readout of a neoadjuvant therapy trial. That was a NeoGAP trial spearheaded by Shishir, who sits on this panel and moderates here, for these patients who have high-risk intrahepatic cholangiocarcinoma with high-risk features. And this study was meant to really be the first of a kind to show to us that this is safe and possible. And in fact, it is. You can see that all patients were able to get the 4 neoadjuvant therapy cycles. A sizable proportion of them were able to get through surgery, 73%. The rate of R0 resection was favorable compared to historical values. And these, again, were very high-risk disease patients with multiple tumors, with nodal disease, with large tumors. And ultimately, what we've learned from NeoGAP is that neoadjuvant therapy for cholangiocarcinoma is possible, it is safe, it does not seem to negatively impact your ability to get to surgery, it may improve your ability to get margin negative resections, and ultimately, it may improve your survival. So with that in mind, there's a few trials that are ongoing right now, both in the United States and abroad, that utilize Gemcis with immunotherapy, like the top 3 that you see, or is looking to use targeted therapy in the preoperative setting. This is one schema of one trial using Gemcis Durva that's being run through the ETCTN, through the NCI. Patients get 4 cycles of neoadjuvant Gemcis Durva, then they get surgery, and then they get 4 more on the back end. At the same time, there's this Optic O2 trial that is the concept of Shishir and Rashna Shroff, who want to really make this umbrella protocol where patients with specific mutations can get that agent early on in the preoperative setting. But to achieve any and all of these trials, you really need collaboration, and I agree with that. At the same time, I want to put in a word real quick about the pump, which, right now we haven't talked about the pump in the neoadjuvant setting, but Bas right here has shown to us that in the advanced unresectable metastatic setting, I'm sorry, not metastatic, but liver-limited unresectable disease setting, a pump with systemic therapy is better than systemic therapy alone. So might the pump play a role in being included in a neoadjuvant trial? That is something to also consider. So here are our 3 suggestions or key research questions that we propose to you. And I don't know if these will come up as a poll question.
No, just go next.
They
Yeah,
will?
it'll come
Okay.
up.
All right, here's the poll question. Sorry. Oh, sorry, let me go back then. Let's go to poll question number 3, which is, we believe it is a research priority to propose and design clinical trials that assess the feasibility, safety, and efficacy of utilizing novel approaches for early-stage resectable disease using common language terminology as determined in the first presentation, incorporating such modalities as immunotherapy, targeted therapy, and regional therapy in the neoadjuvant, adjuvant, or perioperative setting. So let's push this through. Okay, terrific.
Can I suggest that we, from a terminology, maybe, Baz and I were discussing, maybe we remove the word resectable as we just had a different presentation. We looked at resectable, borderline resectable, and locally advanced, and they're non-metastatic. Maybe we should just say approaches for early stage disease using common language terminology. It's a minor thing, but the word resectable may, in the context of common terminology, may
Sure.
get confusing.
But
If
there
you
is a
take
different
out-
population, right?
But then the trials would be looking at different populations.
If you take out the word resectable, you could be talking about early stage adjuvant therapy. It
Okay.
Yeah.
You want to actually add like resectable / borderline resectable.
Biggest thing. Just
or early stage disease
Or localized?
being assessed
Localized.
for surgical approaches, or I don't know, but
Melinda?
This is quite a complicated question. I mean, there are many things that are being asked. I don't know whether you're asking for terminology or you're actually asking for, the design of the trial, or I'm not sure what the question is.
Sure. I don't think we are this question is not asking for us to define the terminology that was in the first presentation. This question is saying once we do settle on common language to determine what early stage borderline resectable and resectable disease is, it is important for us to think about designing these clinical trials, looking to employ these different modalities in a perioperative and neoadjuvant setting.
So trials should be designed specifically for these populations using that terminology.
I like that we're arguing a concept that we all agreed upon, though.
It's
So
a
that's
bit,
good.
bit
No, that's good.
embarrassing. It sounds as if we did not have 5 meetings discussing this already, or it could maybe be interpreted as a strategy to have you vote first and then change the wording.
So my interpretation of the question was exactly, I guess, how you answered it, Hop, right? Is there an importance or a priority placed on looking at neoadjuvant or perioperative trial design?
Yeah.
In some ways, and I mean, I agree with you. I think there's a consensus that that this should be a priority. But to Melinda's point, I almost wonder if refining the recommendation to be a little less verbose and keeping it as broad and open as possible to allow for opportunities for research strategies that niche underneath it might be something to think about.
No, I appreciate that.
Can I?
Yeah, Mike,
Sorry,
too.
but to
Two.
simplify it, I mean, by the fact that you're calling it neoadjuvant, it's resectable disease in some way, shape, or form, right? Or thought to be.
Yeah.
So isn't the priority just to design safe and meaningful neoadjuvant trials? Isn't full stop? Isn't that the research priority?
No, I think that's a very fair interpretation, and I think it's a much less verbose way to put it. And I think it does reflect the spirit of the question. So I appreciate that. And I think it speaks to your point, Rashna.
But if I can make a comment to Rory's point, I mean, I think it's also to design patients that can be, I agree with you with the terminology, neoadjuvant has to be resectable, but it's also to define those patients that are initially unresectable and you can downsize and make them resectable. And that's where the definitions of borderline come into play.
Yeah, but that's the
Conversion.
classification priority, right? This is the perioperative, and the priority should be to get to neoadjuvant trials for these patients, right?
I don't know, I think, Mike 3.
I think some of us who abstained from this from a patient perspective, have not been able to get to the resection point. So it's hard for us to make a concrete decision on whether to agree or to abstain.
Yeah.
For this particular topic. If you took resective out of the way, it loses the power of this portion, but at the same time, if you're trying to get abstain to agree, that would be a way of gaming it. But at the same time, where do the patients that, don't fall in the resection category, essentially, where do we turn?
Yeah, so I think, there's all these nuances. So resectable as we defined it is technically resectable and biologically / oncologically resectable. And then borderline resectable can be technically borderline, but also could be borderline, not just, it can technically come out, but oncologically, we know that if we operate first, we know the recurrence rates are extraordinarily high and the survival rates are necessarily poor. So when you think about perioperative or neoadjuvant or adjuvant, I mean, you could use the word neoadjuvant, you could change it to preoperative, to be honest, and be a little bit more encompassing. But the goal is, in terms of, like we talked about before, micrometastatic disease eradication, tumor shrinkage, quote unquote downstaging, and then also patient selection for patients who undergo these potentially morbid operations, that we hope that there will be a positive outcome on the back end. So that's why we're trying to be, again, there's so many different ways to approach this, and the point of this research proposal is come up with a trial. Now, could it be a neoadjuvant for resectable? Could it be a downstaging neoadjuvant or a downstaging preoperative therapy for patients that are deemed borderline resectable? Could you come up with another adjuvant or a perioperative? It's basically kind of meant to be extraordinarily broad and encompassing. That was the goal of this wording. Rebecca?
I think in the interest of time, and since we have consensus, we'll take one more comment from microphone 1, and then we'll move on to the next.
I think you may have just said that you wanted it to be all-encompassing, but I think there are so many different possibilities under this, and it probably is at some point teasing out what is the priority, because I would argue that even almost the earliest stage cholangiocarcinoma is biologically very high risk. And so those fully resectable ones, having a neoadjuvant strategy is a different question than borderline resectable and downstaging. Those are very different trials. But understanding which of those is a priority for the community is probably worthwhile.
No, thank you. I think that's a great point. And we'll wrap up that discussion for that first recommendation. Move on to the second recommendation, but we've taken heed of all of the comments. Thank you. So here's our recommendation 4. It is a research priority to determine the optimal measure of response, considering radiologic assessments such as RECIST, radiomics, ctDNA dynamics, circulating tumor immune microenvironment, metabolic volume by PET, and biomarker response. So how do we best measure response to preoperative therapy? I think that's a research priority. Yeah, so when you use when you use drugs to treat a cancer before you go to surgery, how do you determine that that was effective? How do you measure that response? Do you go by imaging changes? Do you go by blood value changes, like a CA19-9? Do you go by ctDNA? Do you go by PET activity? So how do we measure that? That's the big question. That's the unknown, and that's why we think this is a priority.
All right, so let's vote. All right, so we don't have consensus. Okay. I'm going to start just because I have a microphone in front of me. So I've two things, and for me it was a little bit of wordsmithing. I think we need to include pathology, path response. That wasn't in here. And then it doesn't actually say that this is for neoadjuvant approaches. This could be for all clinical trials in cholangio. So I thought we needed a little bit of text around the fact that it's involving perioperative approaches.
Terrific suggestions. Any other suggestions or comments? Yes.
The question or the statement says to determine the optimal measure. Are you assuming you're only going to pick one optimal measure, or are you using a combination to come to your determination?
No, I think that's a fair question. I don't think it's going to be necessarily one single answer for every scenario. So, yeah, I think measures.
I guess I was wondering about the definition of response. Is this success of getting to R0 resection, overall survival, postoperatively?
Yeah, I mean, Yeah, I think that's a very good question, and that's what we always struggle with. When we do these trials, ultimately what we care about is overall survival, right? You're going to give this so that you have better outcomes, better survival. But does path response, right, mean that you're going to have better survival? We don't know that. We have no idea. We think it does, but we don't know. So I think that's what we're driving at. The ultimate measure of response would translate hopefully to a survival, overall survival benefit, right? But I think all these other measures, whether you're able to get R0 resection, improve recurrence-free survival, I think those are all measures of success as well.
So maybe response should be changed to benefit.
Okay.
Optimal measures of benefit. And then just for the typing, not pathology, but pathologic response.
Do you think
Sure.
do you think the word benefit correlates with RECIST, radiomics, ctDNA, T-cell infiltration? Those are all responses. Benefit, we're talking about a survival outcome, no?
Sure. I was just trying to give an umbrella. Different.
Jumping in line, I like the use of response, but I think maybe we should put it into context of, to better assess long-term outcomes or something like that at the end of the sentence. So that you sort of put it into context, which I think is what everybody's been saying, about why are we looking at the response? Are we looking at it for neoadjuvant therapy trials? Are we looking at for outcomes from surgery or transplant? I think it just needs something at the end to put it in context.
Although, neoadjuvant approaches are also very useful to just look at biological changes and with no expectation in some of those studies of having long-term benefit. So we can still learn a lot about the way that a drug works, for example, especially in very short course of neoadjuvant therapy. So I would hope it could capture that too. Microphone 1.
Yeah.
And then I see you too.
Yeah, Hi. I just had a question because for biomarker response, like tumor markers for me they never changed, you know what I'm saying? Like there was no fluctuation in that. So does that have to be a reason? Because my tumor markers would never tell you that I have cholangio, you know what I'm saying?
Right.
So that's something to consider when it's not the same for everyone. I know I'm not the only one that probably doesn't have tumor markers affected, so.
No, I think that's a great point, and that's why I was saying earlier that it's not going to be a single measure of response. It's probably going to be a combination of different things. We know a lot of cholangiocarcinoma patients will not have a high CA19-9 level, and we can't reliably follow it as a measure of how the disease is progressing. So that's why we have all these other things that will be incorporated in that measure. But I appreciate the comment. Gonzalo.
Can I?
I can hear you.
Yeah.
Oh, if I can add, so I think what we're talking about is, I don't know if we need to split that to two different priorities. I mean, what we wanted to answer here, and correct me if I'm wrong, Shishir and Bas, is you treat a patient with neoadjuvant, and then is there response, no response, you take the patient to a operating room or not. And the other thing is efficacy. It's very different. So I don't think we can put in the same question determinants of response to the treatment and then determine what you do after neoadjuvant, and the efficacy, which is what we're talking, path response, correlation of path response to OS. So I think it would be tricky to put everything into one. So my suggestion is actually to put two of them if we're going to put path response and correlation.
The first one, if you look at the first recommendation we did, it was trials that assess feasibility, safety, and efficacy, getting to exactly what you said. That's what we were looking at. And then this one was really honing in on response. So we actually, I think, separated it exactly what you said, but with the first one including efficacy, the second one including response.
Dr. Lamarca?
I just wanted to, I think you have there a list of a lot of potential markers, and I wonder whether all of them have the same priority level or whether you want to make a selection of where is really your main priority. Did you hear me?
Yes.
I think we don't really know, right? I mean, if you make the analogy with pancreatic cancer, where there's a bit more research in this field just because it's more prevalent, many of these are promising. ctDNA dynamics is promising, PET response is promising, tumor markers are being used. I think the way I look at this recommendation, at this research priority, is that we're talking about restaging. So the patient has been treated. Both the doctor and the patient have in mind that there is an opportunity for surgery, but with restaging, and this could be with imaging, this could be with all those factors, and we currently don't know exactly how to do this restaging, that at the time of restaging we have additional information, and we need to make up our mind together with the patient that is a resection the best thing to do, because the resection also has downsides. It's risky surgery. And so I think response, the way I look at response, is a measurement at the time of restaging that reflects what we think of as a survival benefit. So if there's a good response, it's likely that the patient will have a survival benefit from the surgery, which should then be balanced with the surgical risk. So I still think a response, the word response, is a good reflection of the situation at the time of restaging.
Go ahead.
Yeah. Here we are discussing surrogate marker of benefit from the neoadjuvant. I think it's very difficult to put that as a research priority while we don't have any evidence of benefit of neoadjuvant treatment. And, you know, from the previous one, I completely agree that we need to have clinical trial to show benefit of neoadjuvant treatment. And if we don't have this clinical trial, how are we able to define surrogate markers?
That's a great comment, Julian. I think all of this stuff we're saying in this one actually would be incorporated in the last one. So anyone who designs a clinical trial will be looking at all of this in a correlative sense. You're right, this is almost a subset part of that first one. I think
Yeah, they're definitely related, yeah.
Microphone 3.
My one comment was about the list of things after the comma. Is that necessary to have them there? Because we don't know right now what the optimal measure or response would be. And it might be a cleaner recommendation that we need to determine the optimal measure or response.
In perioperative studies.
Fair point. Again, all of that probably would be included in our first recommendation. And does our group agree that this is really all kind of part of our first one?
Yeah.
So
Roy,
we can take that into account.
Just move.
Your final.
So I also just wonder, from an impact standpoint, if the priority shouldn't also incorporate prediction, right? Because we don't know what the targets are going to be, and we don't know what the measures are going to be. But as we do this, what would be most powerful is to be able to predict using radiomics, multiomics, cell-free DNA, whatever it's going to be, who may respond to therapy. Because that's really who's going to say should go on trial versus not.
Yep. So to your point, that is exactly built into OPTIC. In the OPTIC trial design, we're actually doing exactly that. So again, all of it probably falling under that first one.
So I just wonder, as a proposal, that we put response back in terms of benefit, because we're specifically looking at how well a specific treatment has had an effect on the tumor. Finish the sentence at response, and if you just put the rest, don't lose it, put it in brackets and just present it. But the statement will be, is a research priority to determine the optimal measures of response. And I think it should be to neoadjuvant treatment.
Right,
So maybe response to neoadjuvant treatment.
I like it.
Okay. So let's finish that.
Should we add the word, like to Rory's point, determine the optimal measure and prediction of response? Or too much? I'm fine leaving it if you want to leave it.
I'm looking at the chairs.
Fine, leave it.
Okay. I think that
And then just
looks-
an end parentheses at the very end. Yeah,
Yeah,
there we go.
I think that
All right,
looks good.
let's vote.
Okay, we're going to relaunch the question. It is a research priority to determine the optimal measure of response to neoadjuvant treatment. Could be any of these things or more. RECIST, radiomics, ctDNA dynamics, circulating tumor, immune microenvironment, metabolic volume by PET, path, and biomarker response. So let's
Has the push arrived?
activate.
We're waiting for the push. Thank you. Push has arrived.
Thank you.
Welcome.
Terrific. Very well done. Thank you very much. We'll go on to the last recommendation for this subsection of surgery. And we didn't really talk about this during the presentation, but our group felt understanding the burden and the heaviness of the surgery that these operations represent, it is a research priority to develop an optimal prehabilitation strategy for patients undergoing resection with or without neoadjuvant therapy, considering nutritional and frailty statuses of the patient. So how do we best optimize patients to undergo surgery for cholangiocarcinoma?
Waiting for the push. Thank you, it's arrived.
Oh,
Just short. Just short of
although,
The disagreeers.
agreement.
I'd like to ask anyone who was advocating to disagree to stand up and please tell us a little bit your thoughts.
Yeah.
Rise up, as the song says.
Can we have the lights up, please?
I agree with the statement, but I will suggest to remove the neoadjuvant therapy because there is not any evidence to use the neoadjuvant therapy, and then I will just only put surgical resection without neoadjuvant therapy.
Do we then get your vote?
So you just need one person.
I will change my vote. We arrive to more than 80%.
John.
Again?
Vote. And I'm 1%, so that sorts it. I don't know idea why.
Can I just ask?
Can I just add to the argument? I mean, I think we often talk about issues that relate to hard clinical entities, but really, how a patient is able to respond to the treatments is vitally important. And it might be that dealing with the frailty is going to vastly improve the outcome in the patient. And we really think we do need to be thinking about this much more. And I'm sure some patient representatives would agree with that. Anyway, I'm the 1% that you're missing.
If I just may add to that, because for the sake of time, we didn't spend too many slides on this because we couldn't predict how much discussion there would be. But just to put this in perspective, for many other much more common cancers like colorectal cancer, we know that actually evidence from randomized controlled trials that prehabilitation is really like not only smoking cessation, but also like helping patients with their diet, going to the gym, in a very formal, structured setting, really decreases surgical complications and improves recovery from surgery. So although this has not been shown for cholangiocarcinoma, I think it's really worthwhile to investigate this.
Okay, so the suggestion was to remove neoadjuvant from the phrase. Any objections to that, Boss or Shashir?
Again, they're all kind of connected. So if we put this as an RFP, we said plus or minus neoadjuvant. So if someone's writing a grant for a neoadjuvant trial and they want to do a prehab, they have a neoadjuvant protocol and they want to do a prehab strategy, I think that's applicable. Again, it would be kind of all mixed in with that first one we talked about. So there's lots of overlap here, but we really try to just focus this one on prehab.
Was there a reason to exclude the plus minus neoadjuvant?
Someone had just made a comment. That's
standard. Yeah, I mean, it's not standard of care, but it's being more and more frequently used, particularly in intrahepatic.
And I think just one quick point. We said plus minus, meaning it's not obligatory. But the other thing is a neoadjuvant therapy, especially in a frail patient, is a great opportunity to prehab them that you wouldn't have if you went to surgery up front. So I think that is one of the things, one of the potential benefits of neoadjuvant therapy in that particular setting.
So I'm going to propose two things. One, that we revote with it phrased as it is here. And secondly, if you are choosing to abstain, it's actually, I think might be nice is to not hit abstain, but just don't vote, because we've had many that are just kind of right at that boundary, and even the abstentions are changing that proportion a little bit. But let's go ahead and vote.
Please
All right.
revote and
We'll
push.
relaunch the question.
John, did you vote?
All right,
Fantastic.
there we go. Thank you very much.
All right.
Thank you.
Thank you, Hop. Appreciate it.
We have just over 34 minutes.
Yeah, we're
I think we're doing good on time.
5 minutes ahead of schedule, surgeon style. Now we'll go on to the last topic, which has no controversy or no discussion whatsoever. I say that in jest. Carrie Lunsford will be talking about transplantation for intrahepatic and hilar cholangio.
we have the
So I
slides,
just want to
please?
make sure that the fact that they went over 5 minutes, it doesn't count against my 10 minutes, right?
Not at all. You have all the time in the world.
Okay.
Well, you have your 10 minutes.
All right, so to switch directions a little bit, as you said, no controversy in transplantation, and the transplant surgeons can't even agree amongst themselves. So I'm going to lay out what data there is, as well as what needs to be done, which is a lot. So we've already gone through the reasons why for liver transplant for cholangiocarcinoma, what the issues are with surgery. For transplant specifically, it offers an alternative for resection in certain patients because, one, we can achieve tumors-free margins, we can treat the parenchymal invasion, and we can remove the underlying tumor. But really for transplant, what we're talking about is historically only hilar or perihilar cholangiocarcinoma. But more recently, we've also have data for intrahepatic. So in the United States, which is where I practice, we have two current indications for MELD exception or extra points to prioritize patients with cholangiocarcinoma. The first has been around for a while, established back in about 2010, which is perihilar cholangiocarcinoma. So patients who have unresectable perihilar cholangiocarcinoma less than 3 centimeters in radial diameters, these are early stage patients, no lymph node disease, no intrahepatic metastases, and there must be a institutional protocol approved by UNOS, so only certain transplant centers in the US will participate. For intrahepatic cholangiocarcinoma, this is a new indication that was just approved, and we've only started voting on this in the National Liver Review Board since February, but we're very excited to have at least something. So this is for a solitary lesion of less than 3 centimeters on a background of cirrhosis, and the patients must have disease stability or response to chemotherapy for at least 6 months prior to being listed. There's other malignancies that are included, but really right now, today, we're just interested in cholangiocarcinoma. So I'm going to break them down by site. So first, we're going to talk about intrahepatic cholangiocarcinoma. Wow, my slides really got screwed up, so I apologize.
You can see.
They were formatted much better on my screen. So anyway, so there's a couple, I'm going to sort of glaze over. There's a bunch of studies that have been done. For intrahepatic cholangiocarcinoma, there's sort of two groups of studies that have been done. One is a retrospective analysis of patients who have been incidentally found to have cholangiocarcinoma when we take the liver out, so on the explant pathology. And so usually these are patients who may have gotten just local regional therapy or a treatment or ablation of the tumor, but generally did not get chemotherapy. And so Dr. Sapasoshan, or Gonzalo over there, has done a lot of these studies, and they've done multi-center retrospective analyses, which have shown that patients with very small intrahepatic cholangiocarcinomas do very well in terms of low incidence of recurrence and and a good overall survival after transplant. However, again, this is mostly retrospective studies. It's hard to diagnose patients with a small tumor of less than 2 centimeters in a cirrhotic and know that it's for sure that it's cholangiocarcinoma. So the French subsequently looked at patients who have larger tumors. So this is a cumulative, or the largest tumor measuring 2 to 5 centimeters. So there was really no limit on the number of tumors that they used for this. But they found that patients who underwent transplant with a largest tumor size of less than 5 centimeters also did very well. Again, this was a retrospective study. Patients had, in this case, all received some sort of bridging therapy like a TACE RFA or alcohol ablation. So then subsequently, there's a second group of studies that have been done that have looked at basically all comers, so patients with or without cirrhosis. And those patients were, these studies have been done a little bit more prospectively, in which case patients have really, we haven't really limited the number of tumors or the size of the tumors that are being evaluated, but we're really looking at the patient's biologic response to therapy and to see if patients who have a good response to chemotherapy or local regional therapy would be good candidates for liver transplant. So this was the protocol. The first protocol was really initiated from Houston Methodist and MD Anderson while I was there at Houston Methodist. And so we looked really for patients who had a 6-month sustained at least sustained response or partial response on chemotherapy. And we did allow patients with salvage transplant. Within our first group of patients, we had an 83% overall survival and a 50% recurrence-free survival at 5 years. They've followed this up, I think now, I've just heard from Dr. Kadali that they're up to about 60 patients who have been treated. And this is the follow-up with the first 18 with a overall survival of 57%. So still really good response for those patients who are eligible. The problem is that which patients are eligible, which treatment should be giving the patients, and we don't really know a lot of those things because most of these studies are still, 60 patients is a lot, but it's not that many when you look at like the oncologic studies looking at chemotherapy responses. They have recapitulated some of our results just recently in Norway with the Tesla 1 trial. This is, so far I think they've transplanted, I think, 5 patients who've received, they have 1 or 2 patients who have recurred, but all patients are still alive on their trial, and these were just hot off the press in 2025, just this last month. One of the other questions that we don't know is, should we be giving systemic therapy or systemic therapy plus local regional therapy? Again, all of the studies that are out there are limited to a lot of times less than 10 patients. UCLA did a sub-analysis of patients that they had transplanted with intrahepatic cholangiocarcinoma, and they found that patients who received local regional therapy plus systemic therapy, this line at the top, do I have a, maybe, nope.
Red takes you back.
I was looking to see if I had a laser pointer on here. No. Okay. But anyway, those patients had a good response there. We've seen basically the patients who receive that in some small studies have good response. As I said, there's been a lot of very small studies that have been done to date. Here's sort of the combination of everything that has been done on all the trials. Other things that we need to look at in this is risk factors for recurrence. These have only been able to be evaluated in a very small number of studies. Some of the things like tumor size, number of tumors, these are things that are really unknown in transplant as to what the optimal candidates are. We also need to look at biomarkers for recurrence and for good outcomes pre and post transplant, as well as the use of ctDNA. and targetable mutations and what the use of different types of immunotherapy or chemotherapy would be for these patients. So as I said, there's lots of different areas for question for research in liver transplant for intrahepatic cholangiocarcinoma, but the initial results are very promising. In the US and abroad, there are currently multiple trials that are going, that are evaluating this for prospective studies. Most of them are single center studies though. So there's not a lot of multi-center trials that have been available. So now to switch to perihilar cholangiocarcinoma in my last 2.5 minutes. The patients who receive liver transplant for perihilar cholangiocarcinoma primarily have been done under what's called the Mayo Clinic protocol. So this is the tumor size of less than 3 centimeters with a malignant appearing stricture that are unresectable. They cannot have any intrahepatic masses. There is also no transperitoneal biopsy or prior surgical resection allowed for these patients. And those patients get treated with both chemotherapy as well as radiation therapy prior to transplant. Looking at the original Mayo outcomes, the black line on top, which shows our transplanted patients, had a significantly improved survival over those patients who received surgical resection that were somewhat matched in terms of their initial diagnosis. This was confirmed, although not quite as good as the initial Mayo outcomes, with a multi-center retrospective analysis from 12 different centers around the world. But there's a lot of questions that have come about. One is this avoidance of transperitoneal biopsy. This actually excludes patients prior to transplant because they'll arrive at our center and they've already gotten a biopsy from some other outside place. Looking at some of the surgical oncology literature, the incidence of peritoneal metastases from by biopsy type, there's really no significant difference. So this may be something we need to reevaluate. As well as the actual need for neoadjuvant chemoradiation prior to liver transplant. One, the need for radiation therapy itself, as well as any need for transplant. So the Europeans have looked at this and they found that there is an earlier risk for recurrence without neoadjuvant therapy, but the operative morbidity can be greater in patients with neoadjuvant therapy. And of course, larger studies would be needed. With regards to the question of the need for radiation, the results have been fairly similar, but this is a small cohort of patients. There's really no difference in overall survival with or without radiation. So, I think there's a lot of area for additional study and collaboration, but I think the overall theme is that we need to have larger studies. We need to have multiple centers that are involved so that we can have enough patients in order to have a meaningful result for analysis. Again, for perihilar cholangiocarcinoma, use of immunotherapy, use of targeted therapy, whether or not we should be doing lymphadenectomy at the time of transplant, as well as any need for the adjuvant therapy after transplant. There's very few studies that have looked at these things, and there's still questions that need to be answered. There are multiple trials that are ongoing. Most of them are in Europe, I have to say. And I have other comments I could make on that at some point, but as to why there's not trials in the US. But I think there's need for international collaboration. And that really gets us to our 2 questions for transplant. And I think we can go to the actual questions, right? Yes. And I can read off there. It's only 2 minutes over. It's good for me. Okay, so the first is, it is a research priority to propose a protocol for transplantation that can either be single institution or multi-institutional and should be anatomic site specific. So either we should be looking at intrahepatic cholangiocarcinoma trials or hilar cholangiocarcinoma trials, as opposed to ones where we combine all types of cancers together so that we can have a larger number of patients.
And going forward, I'm just going to ask that you restate the recommendation in terms that our patients and caregivers can also understand, if you could.
Yeah. So basically what we're saying here is that we want to have clinical trials for transplant, either run at a single center or combine results with multiple centers together. And we want the trials to specify that they're going to look at cancer that's intrahepatic cholangiocarcinoma or cancer that's perihilar cholangiocarcinoma. Is that hopefully clear?
All right, let's vote.
Guess I have to vote too.
Waiting for the push.
Yeah. Oh no. Oh.
Clap.
Oh wait, we're back. We're back. Must be 79.5.
Reese.
All right.
Next slide.
No, nobody else touched
Before
their.
it changes.
All right. Let's see if we can get through the second one with consensus.
Can I make,
Go ahead.
Sorry, just quickly on the pass. I don't think it'll change the consensus, but I just wanted to word it a little bit more strongly. Instead of proposing a protocol, it's actually developing a protocol. Let's go beyond just the proposing and see it through to completion.
I agree with you, and I like that wording better.
Excellent. Develop. It is a research priority to develop a
Develop,
protocol for
or I would say develop protocols.
Yeah.
I think there can be more than one.
Thank you.
Sorry,
Can you take a
use the
microphone,
microphone, please? I
Jasper?
can't hear you.
Just to make it a bit stronger, so remove single institution and make it only the multi-institution, since all the trials so far were so small.
Yeah, I mean, I think that, I think ultimately multi-institution will be a much more powerful result, but there's a lot of questions that need to be answered. And I know that sometimes it's hard for recruitment. I mean, this is one of the problems that we've run into in the US with running and designing studies is one, well, it's already, transplant's already an indication for cholangio, so why should we fund a study for it? And then two, what is your comparative group? You can't really do a randomization because a lot of people feel like, well, if we can offer transplant, why would we offer them something else? Because the patients aren't really offered any other type of therapy, in which case you're basically doing, instead of a randomized trial, you're basically just doing a single-arm prospective study. So do we need to re-vote with the new wording?
I don't think so.
No? Okay. All right. So the second question, I think we can go on to that. It is a research priority, is a research priority to develop and maintain a prospective registry of transplant for cholangiocarcinoma that can either be US-based or international and should be site-specific, intrahepatic or perihilar. So basically, what we're saying is that the transplant centers need to get together and they need to develop basically a prospective registry where anytime we do a transplant for cholangiocarcinoma, we put our data into that registry so that we can study, even if we're not doing trials, we can still study the outcomes. And we need to be, but it needs to be very granular. The way that transplant registries currently is based on the data via UNOS, and that is not specific for cholangiocarcinoma, especially since it's such a small proportion of the number of transplants that we do for cancer. So most of the data that's collected there is based on hepatocellular carcinoma.
All right, let's take a vote.
Oh.
Strong consensus.
That's even a stronger
Fantastic.
consensus. Anybody have any comments or?
Yeah, I would actually just love to say transplantation data, prospective registry of transplantation data. I just think that.
I like
'cause it is
that.
a-
Yeah.
Yes, but is that person?
Yep. Pishton Kasi, Medical Oncology at City of Hope. I just had a quick comment. As we expand more patients getting transplant for intrahepatic cholangio, a lot of these patients are still treated initially in the community. So I think there's also a need to have awareness of advocacy of what would be the preoperative regimens or what they should be getting, what they shouldn't be getting. Is it okay for them to be on immunotherapy as they go for a transplant? So I think it's important not just for the transplant centers to have this registry, but also have awareness of this or a broad consensus.
Yeah, no, I think it's a very good point. I'm always happy to talk to the treating oncologists and non-transplant surgeons, early on in the process. I would recommend that you sort of have relationships with your regional transplant center to see if they do offer these types of options, and if they do, have sort of some relationships there. I'm always happy to go talk to centers or individuals, in the New York City Northeast area, about different protocols and things like that. And it's center specific, so I can't answer which are appropriate and which are not. I know that my center is very liberal into our what regimens that we will allow, but there are centers that strictly adhere to the traditional Mayo protocol. And I think that's one of the areas where we need to study, because we need to know, can we go beyond those original indications? Can we use immunotherapy? And, even though we're doing it, doesn't necessarily mean that it's the right thing to do, because we don't have good data to say one way or another from transplanted patients.
I just wanted to reiterate that specific point as well, that there are some centers that the protocol is so strict that even if they got one cycle of a chemo that wasn't part of their protocol, they won't consider that patient proceed forward. So I think there's a need to have some consensus if it makes biological sense.
Yeah, no, I agree with that, and I think that there's also the second opinions are there for a reason. So you're always welcome to go to multiple centers to get evaluated or assessed.
But I think your point goes under the last recommendation, which is as these protocols for transplantation are developed, those can be then disseminated and serve as a standard.
Dr. Ilyas?
So I agree with both priorities. I've always been an advocate of having very clear, well-defined protocols for intrahepatic and perihilar. I guess my question was just, did we really need two separate priorities? If you have clinical trials and protocols, you kind of have the registry as part of it, or shouldn't you? Right? So I'm just curious why we had two separate recommendations.
I think they're not necessarily the same thing. I think they're, right now you have multiple institutions doing protocols, but they're not sharing the data. So what we mean by a prospective registry, like a web-based global platform that has standardized fields that everyone is putting in, so we could actually create a national, international database that you can follow this, which is not the same thing as a prospective protocol for putting patients on transplant, because that would imply that everyone's doing the same thing, versus right now everyone's doing different things.
Yeah.
More standardized way of keeping track of the data.
We see both of you, so go ahead.
Thank you. I just wanted to advocate in order to include in this registry and database not only the topographic classification, but also the histological classification, because especially for intrahepatic, you may have small and large bile duct that could behave differently in resection and also transplant setting. So I think this is very important for understand the outcome.
So you're saying that to have a standardized histologic criteria that we need to be reporting on, and I think that we'll need to get some buy-in from the pathologists for that, because I don't know that that's standardized across institutions.
Or at least like keeping track of the data.
Yeah, exactly.
And having it as a
Well,
data
I mean,
field
if
in
there's
the
something that
registry.
we should be keeping track of, I think it's good to get the buy-in from that, which is why we present these things here. I would say the one thing that the reason there's a difference between trials and registries. So just historically, and this is a little different for transplant centers, We can transplant patients for any indication, and that is decided, what the indications for transplant are decided by this transplant center. It's not necessarily has to be under a clinical trial or has to be under X, Y, or Z. That is the decision of the transplant center itself and the transplant review board as to whether or not a patient is a candidate for transplant. Whether a patient will get extra points to get prioritized on the transplant list is a national UNOS determination. But if a patient is getting transplanted for an indication outside of what is recognized from UNOS, they can get transplanted with either a living donor or they can get transplanted with a sort of a marginal or what we call orphan liver. And that's been done in many cases, and I would say in all of the patients, at least initially, that were transplanted at Houston Methodist. Yes, Gonzalo.
I would just, the only thing is that that's specific for the US, like in the rest of the world, it's way more, like you just can't do it that way. So I think if we're, thinking about this as a global initiative, in most places you can't.
Yeah, and that's a very good point, Gonzalo. And I think that's why we see more trials internationally for cholangio, for transplant, than we're seeing in the US. It's very hard to get a trial started or approved. It took me 3 years to get our trial open at my center.
Mike 3.
Yeah, data is king, as we're learning. In the research world, there's something that's called design space, and there's something that's also known as quality by design. And what we're trying to do is we're trying to expand on acceptable parameters as much as possible. And then what happens is we end up with a design space with more palatable operating conditions. The same thing I feel should be taken within other fields because it has increased the chances for loss to almost zero by operating within an approved design space. But again, you can't do that without data. So the way this data is collected, I think, is extremely important. Whether or not it can be used today, it could be used at some point.
Okay.
Dr. Jobly?
I just want to point out that, some people here like Sudha, Gonzalo, et cetera, have already set up guidelines for pre-transplant therapies, which are known to transplant people. So I heard the questions, what treatments can you give? So ILTS has published some proposed guidelines. But I think, honestly, Kerry, the problem here is not the oncologists, it's the transplant surgeons themselves. They have to be willing to create a registry and maintain the data and publish this information.
Yeah.
And I know, having collaborated with some of you, it's a hard ask. Nobody really wants to. It's hard to get these people together to actually publish their data and get a registry together. So this poll should really be to them. And I would say that we get small gains in medical oncology that we make big deal about. The gains in transplant are huge. So it is a priority for our patients that we should get these registries out so that patients know where to go and who is benefited and not.
Yeah, agreed.
Well, we have had a fantastic session. I want to thank the Surgical Working Group for all of their hard work and for everyone here for the contributions. We have stayed perfectly on time, and we will be back in a half an hour from break to do the Industry Working Group.